Okay, so good morning. Thanks, Dr. Riker and AWE for inviting me to give this portion of the talk today. So I'm going to be presenting a few cases and hopefully may or may not stump you. So we could dive right in. So the first case is a 70-year-old gentleman with a history of sleep apnea, aortic stenosis, regurgitation, atrial fibrillation, pretty much a sick guy. Had a history of cholecystitis that required a cholecystoscopy tube, and he was a non-operable candidate at the time. And so over the time that he had this tube, it was complicated by a leak. He had an abdominal fluid collection. What they found on imaging was this cholecystocolonic fistula. And so I'm going to start and stop this video at different locations just to kind of get everyone's thoughts on this. So here we are at the hepatic flexure in the colon, and we're looking at this defect here on the left, and the colon, the actual lumen of the colon is down below around 5 o'clock. Oops. And so, sorry guys, it just doesn't want to pause. Okay, so what I'm going to do is pause here and kind of sample some ideas and thoughts from the panel. First of all, we actually do know that this is a fistula. We've confirmed it on fluoroscopy here. So we're injecting methylene blue, and you could see actually the syringe here on the fluoroscopic image here on the right side of your screen, and essentially we're injecting, and you see methylene blue coming through the fistulous tract that is seen through the colon. Okay, so I'm going to stop here. Any thoughts, considerations, concerns?
Please feel.
Yeah.
So you found this, but how symptomatic is the patient? I know they're chronically sick, no other obviously surgical options, but are they?
So pretty symptomatic. He has fecal matter coming through the tube. It has smoldering infection intermittently. He's hospital. He's still staying in the hospital. So we're trying to figure out what to do next.
I guess I'd just be curious. I'll be curious what others say about closure. I think closures can be very difficult on the luminal side here. But one thought could be, could one exclude that area from the biliary side and put in a covered stent, maybe even a partially covered, permanently blocking the cystic duct with ERCP and kind of just see what happens. I don't know, just a thought.
So just to clarify, it's not working, but so that'd be putting in a fully covered stent to cross the cystic duct, exclude the cystic duct, and then that way you just let it be a permanent fistula between the. I like that. I'd vote for that.
Okay. Any other thoughts? What would be your consideration for closure here? And would you attempt it? And if you would, what would you do?
And sorry, where was the fistula opening into which area of the colon?
Hepatic flexure of the colon is connecting directly to the gallbladder that currently has a cholecystostomy tube.
I mean, let's say you want to go down the closure route. It's a fistula. I'm assuming, that mucosa is not super healthy, so it probably will be harder to close, to your point. So something like an over-the-scope clip or regular clips may not work. So if you could get your suturing device there, maybe, or maybe an X-Tac situation where you can try to embed the studs into normal tissue to try to bring it together. You don't need really a super tight seal. You just want to try to divert flow and then go back from above and deal with the bile duct and or try to internalize that PERC drain.
One thing I learned about the fistula tract is that once it's chronic, the mucosa there actually is re-epithelialized. So for us, even if you're trying to use the clip and trying to close it, eventually it's just going to fall apart. So we have to actually tackle the actual fistula itself. So the example for us, the typical patient that we take out the peg and they have a gastrocutaneous fistula is that you have to denude the tract first, whether it's cauterization, basically of some sort, then subsequently use a vascular clip or some closing device to be able to do that effectively, because otherwise, if you just close it alone, the fistula will then reopen it back up because you essentially got epithelium to epithelium. It just doesn't stick. You have to denude that tract, so it depends on how chronic nature of this as well. But I do think the vascular clip serve its purpose, especially an angle on the colon, where if you're able to pull that into the cap, I think that you will actually be able to do it more, I would say, effectively than other techniques.
I'd like to introduce 3 new panelists that you haven't met yet, hopefully. Dr. Paul Cork is an advanced endoscopist from Hoag Hospital. Dr. Katie Blevins is our foregut surgeon and bariatrics from Hoag. And Dr. Woo-Jin Kim, who is one of the therapeutic experts, along with Dr. Andy Gabb. I'm sorry for the interruption.
Sorry, guys, I didn't realize we were going to be speaking.
Okay, so all valid points. We kind of did go down the route of closure, and to your point, we did realize that the tissue needed some sort of treatment, potentially before we started closing it. Getting a suturing device here would have been actually quite challenging because the anatomy was very tortuous leading up to this location. So we decided to actually use X-Tack. And so, I'm playing it again, but it should go pretty quickly. And so we start using APC to start treating the actual tissue. And then so sort of at this point, if you guys were to think about your plan of attack for closure, well, I'm going to keep playing the video, but what will your considerations be here in closing this with X-Tack? In terms of directionality, location, tissue integrity. So we actually end up using 2 separate X-Tacks because the fistulous opening was actually quite large. And then just to reinforce over the X-Tack because, the tissue, understanding the tissue was actually not super healthy in that area, we took just 2 through the scope clips and actually placed it over those 2 sites. And this is kind of what it looks like towards the final portion. So this patient ended up doing quite well after this. He got out of the hospital within a week, and now we're looking towards him being an operable candidate for ultimate removal of his gallbladder. But curious from your thoughts, actually, what do you think here as a surgeon?
Yeah, it's someone not being an operative candidate. It's so multivariable and it's a moving target. So even if a surgeon has said no once, it's always a good thing to remember. To the point about fistulas, in surgical training, we have this mnemonic to help us remember all of the factors that we should try to modify for a fistula, and it's FRIEND, which is, I don't know if you guys have heard before, but it's for foreign bodies, radiation, inflammation or infection, which is going to be a big one here. Epithelialization, neoplasm, so cancers, and then D is for distal obstruction. So those are our modifiable factors that we can do to set ourselves up as favorably as possible. So I agree with kind of treating to remove the epithelialization, because if you try to sew your hands together, you can have suture in there for 10 years, but as soon as you cut the suture, they're going to come apart. They're never going to heal. For the inflammation here, we do have acute cholecystitis still. We have inflammation. These tissues look totally friable. Sometimes waiting for them to mature and fibrose a little bit can at least help with approximation of tissue. But then again, if they're more fibrosed, you might have a little bit less ability to get them to heal together. And so it's a fine line of how you do that. But even though we have, in theory, kind of closed things off, if the patient's able to, I would think probably as long as you can, cholecystectomy might still be indicated. And I would bowel prep first.
When you consult the patient and you say, we're going to attempt to close this, what do you say to the patient? What is the expectation? Like, how long is it? Are you expecting this to beautifully close on the first try, or what is our expectation?
Yeah, so I usually counsel the patient that it depends on the size and the health of the tissue, the size of the actual fistula and the health of the tissue. He maybe coming back and forth with some sort of smoldering infection, may actually get better, but then not get better. So almost giving him anticipatory caution that this could be an ongoing issue that ultimately could require surgery. And so we actually didn't know the size of this fistulous tract until we actually got there and injected methylene blue in contrast. And that's sort of how we navigate it. What do you think?
I was just going to ask, would you ever think about an over-the-scope clip after the X-Tack brings everything together? I don't know if anyone's done that, or do you worry that's going to cause more ischemia and open up again? Or?
I think, I mean, from my perspective, both could have been potentials here. I think maybe just for like time's sake, we were there anyway. It was a torturous anatomy, getting the Ovesco clip on and then getting there again would have been challenging. And then because the fistula was a little bit larger, I didn't think that one Ovesco would have actually been enough to capture it. And then, so then creating two with a potential separation seemed like maybe a challenge at that point.
And then the success for these kind of cases actually depends on two factors. One is the fistula itself, but the second one is the source control, which is the gallbladder. So if you're not addressing the underlying source, which is the infection source from the gallbladder, no matter how tight you're trying to close this thing, it will open back up. Essentially, the underlying, source of this or cause of this is still the gallbladder. So I think the success, to highlight the point Dr. Riker asked, is how successful it's going to be. It depends on the other factor as well, which is something outside, unfortunately, out of control. But we have to address the gallbladder.
Yeah.
So yeah,
Awesome.
going back to what I said first, X-Tack and then deal with the gallbladder.
Yeah, you called it. Yeah, exactly. All right, so I'm going to move on to the next case. A 58-year-old gentleman with a history of HIV, uncontrolled viral load, recently diagnosed cholangiocarcinoma, had a history of biliary obstruction, requiring biliary stenting, and he had initial improvement. Then he developed some fevers over the ensuing 10 days and an elevated white blood cell count. And his imaging had revealed these tumor abscesses in the liver, and that were originally treated with an IR drain placement. But post-operatively, he didn't continue to get any better. He still had ongoing sepsis, inadequate source control. They took him back to IR, tried upsizing the drain, and then they kind of asked us, like, is there anything left to do, because he was still in the ICU and very sick. And so this is a CT scan just showing here, I don't know if my cursor, can you, okay. So this is the collection in the liver. It's a necrotic tumor collection. Here that you see coming in is basically the drain that was placed with IR. Here, there's a pigtail coming from through the skin. And then here is this potential sort of tracking of this area into what could be the GI tract. So just initial thoughts here from the panel. What do you think could be happening here? I could play the video again.
Are your stents clogged? I mean, that's one thing. The cause of the abscess to begin with, you got to.
Also, I was going to say, I don't know what the pre-procedure imaging looked like. Was there already tumor there, and then maybe it wasn't viable tissue, and when the ERCP occurred, you injected into tumor?
All great questions. So before this, before we did the ERCP, he did have a smaller area, that same location, but it was smaller. And so we went in, did biliary stenting, tried actually getting a duct that connected to the collection and place a stent there, but there was no actual connection at that time. And so prior to this image, we had done an ERCP on him maybe about 10 days prior. And so we didn't think that the redoing a biliary stent would be helpful here. Okay, so this is what we see when we go into the duodenal bulb. Any initial thoughts? Any feelings about what this could be, could not be?
I'm just thinking, what a disaster. That's all I'm thinking.
Yeah, this is a challenging case, and multiple teams were involved here, as you can imagine. So I'm gonna.
What exactly, can you play the clips first? To get
Yeah,
a
absolutely.
sensation?
Yeah, let's see. Yeah, okay, so that area in the duodenal bulb, we took a forceps and we kind of moved it out of the tract. And we took our scope and actually started going in, diving into that tract, and this is what we start seeing. And then, so I'm going to keep playing it.
So this is like a collection, like a,
Yeah.
So you entered the abscess.
So we entered the abscess
from the
through the
bulb?
duodenum. Sorry?
From the bulb?
From the bulb. And then what you see here is on the right is actually the pigtail from the IR drain. So it's clearly the same collection that was seen on CT, and not the biliary stent that we placed, although that was a thought that whether or not we were looking at the biliary stent that we placed endoscopically through ERCP. But on fluoroscopy, this was the actual IR drain. And so what would you all do now? I'm going to pause that. So this is the entrance to the cavity, and you just saw the cavity. It's all necrotic tissue, almost looks like a pseudocyst cavity at this point. But now, at this juncture, what would you consider or think about or want to know?
I mean, you want to put a couple pigtails in there and,
Yeah, so like a couple of things in here. One is like, good morning.
Good morning.
Good to see you. So first, when infection, like what is the status of the tumor? How big was that? Is it an infection itself, or is a tumor necrosis involved in that as well? So these are the two separate things.
Yeah.
And so if it is just an infection itself, then it's like not an easy solution. You know, you have a drain there, you have a communication with the GI tract, you just gotta keep the whole thing somehow. And but if it's a tumor, then that's more problem there.
Yeah.
So it's in that case, I think that gonna be really tough to deal with it. Sometimes they even need an embolization if they start bleeding or something. And so it's this one looks like just an infection. So
It's an infection related to the tumor, actually.
these are
so it's hard to tell these.
So it's, yeah, so it's the tumor location there that's infected, and we consider it to be infected.
different thing.
Yeah.
So
Yeah, you mentioned at the beginning, I missed it, that the patient is HIV positive.
Yes.
Can you comment on the HIV status? Because as you know, if the patient has AIDS, your differential diagnosis is completely different from what we're actually discussing now. So are you able to elaborate more on the HIV status? And
Yes, so uncontrolled viral load, and so was on ART therapy, but lost to follow-up. And then he came into the hospital with a new diagnosis of cholangiocarcinoma.
Okay, and the CD4 count, all that is, the CD4 count? and-
CD4 count, if I remember, was below 200. It wasn't.
There you go.
AIDS.
I think it changed your differential diagnosis significantly at this point, right? Basically, it's an AIDS patient. I think that when all of us were GI fellows at one point, you know, we see these, but fast forward 30 years, I haven't seen these, but I suspected that the differential diagnosis need to be broadened significantly at this point, and I have to go back in the book and look at what are the cases of AIDS presentation of these kind of cases, but that's not a consideration I think we should entertain.
Yeah, absolutely.
Since we have a surgeon on the panel,
Yeah.
Dr. D'Souza, please join us in this management of that disaster.
I mean, I will say, HIV/AIDS aside, because I absolutely agree, it completely changes kind of what you're thinking about in terms of healing, controlling infection, all of those pieces. But part of it is, we know there's a tumor, there's an infection. Is ongoing infection, rising white cell count, things like that related to, are we having ongoing contamination from the GI tract? The biliary drain seems like it may be working well, so downstream obstruction and diversion are usually the things that I think about. Are we trying to offload the bioburden that we're putting into the cavity so that that drain can work better externally while we're controlling infection? I mean, aside from AIDS just really throwing a wrench into the works, which it sounds like is kind of what's going on with this.
Right. And, yeah.
what about bypass? Where you suture the pylorus, GJ, and leave that area
Yeah.
to
that's-
divert secretions. You don't have, it's cancer though, so again, I don't know how easily this is gonna ever heal, whether you put pigtails or divert secretions.
Right. So I love all of the discussion because, so this guy was still in the ICU. His white count was probably 40 at this point. And so we were trying to do source control. That original picture showed that there was sort of almost a blockage of that fistulous tract, that there was some tumor infected material there. So we proceeded to actually treat this like a pseudocyst. And we went in there and we started debriding all of the necrotic tissue. And at the end of it all, it kind of looked pretty good, if I can scroll through. We took out quite a bit of necrotic tissue, landed in the stomach, same thing as you do as a necrosectomy. And so started uncovering some somewhat healthy-ish mucosa in the back wall there. Now, we also knew that the prognosis of this patient was quite bleak, and so we wanted to still leave an access point and a drainage point endoscopically. So we landed an axial stent and put a coaxial double pigtail, so treated it exactly like a pseudocyst. He got better, but unfortunately succumbed to the rest of his disease in the ICU, and he passed away. Okay, next case. So this is a gentleman with cirrhosis secondary to alcohol use. It's decompensated, had gastric varices that bled in the past, reportedly had glue and EUS coiling 3 months prior at Outside Hospital, and he presented with anemia and melena. His EGD, performed by a general gastroenterologist, had revealed oozing from a IgV1 varix. And he was transferred because they considered that this was a treatment failure for BRTO to Cedars-Sinai. While he was admitted, he did respond to red blood cells. And so we did an endoscopy 2 days later. This is what we're staring at when we're retroflexed in the stomach. We're looking back on ourselves. And here we see varices, IgV1 varices. Now, I'm going to pause here and get some preliminary initial thoughts from the panel. Any questions?
What was
that
the
you
cause
asked?
of his cirrhosis? His liver problem?
Alcohol.
And is he still drinking?
Yes. It is considered that he's still drinking.
That's the first part of the problem.
Right.
I mean, they don't look overly large, and I don't see much high-risk stigmata unless it's hidden sort of on that underneath side, but just a comment on the
Yeah.
size.
Agree. Do these look like varices that were treated with coil and glue before to you?
Yeah, again, even we treat with glue and coiling, you don't hit them all. So unless you can decompress them all, you're not necessarily actually addressing the underlying, basically gradient pressure. But I'm curious to find out, this is a situation when an EUS scope might be helpful to evaluate these varices and also address the status of the coiling and how effective that was. But yeah, those certainly doesn't look very prominent or scary to me, like the typical lesion that would otherwise bleed.
I'm sorry, you said the presentation's anemia, or was it?
Anemia and melena. Yeah. And very mild hemodynamic changes. And he recovered well with 2 units of PRBCs.
And he gave the 2C in the interim, or sometimes these patients have that friable?
No gave. Yeah.
So can I ask a stupid question? When they're moderate size like that, and you're not entirely sure whether a patient has melanoma or not, and there is no high-risk stigmata on the varices or this, would you just let it go? Especially if the guy is actively drinking. It's not like,
Yes, I was thinking that myself, actually. Doesn't look too bad now.
no, especially it seems like all our efforts should be towards helping him stop. But I could be wrong.
Right. We're concomitantly trying to
It
do
would
that.
also be good to know how much collaterals are there, and because it's just, for the collaterals varices, the difference is one is extramural, other is intramural. So I want to know what the collateral status is out there and how much is showing into the stomach.
Awesome. Great. So if I could point out this area of the varix, in the previous endoscopy, it was a poor image, so I'm not sharing it, but it looked like that was where some oozing was coming from. So we particularly started looking at this varix and the rest of the anatomy. So this is the EUS, and we're throwing on some flow here. And they're pretty large varices, so I'm going to pause here. Yeah, so that's some large varices here. Pausing here, any thoughts?
Addition coiling and gluing.
What are we going to do?
If you look at the gastric wall, there's quite a bit extramural here. And
Yes.
that's where looks like probably the feeder is in that area.
Exactly.
And that's, now it's decompressed, but that does not mean that it's not gonna open up again. So this one, looking at those collaterals, we gotta do something before it opens up.
Yeah, totally. And so now that we've gone down the coiling and glue pathway, so how do you determine what coils you use, the length, the size? And if you can comment a little bit on the technique or your individual techniques.
I can say I always try to use a 19 gauge because I just like the larger coils, and it's just simpler to deliver. So whenever possible, I'll use a 19 gauge needle.
Yeah.
And I'll put as many coils as I can. I'm
Awesome.
big into that. I was just going to say, lately, we haven't done as much of the glue, although I think doing two things is better than one. It's a very sticky situation for the nurses. And
No pun intended, right?
So, but there is interest. I'm interested. I don't know if gel foam is another good ancillary technique that the Brigham group really sort of pushed, and I'd like to do it. But
So first thing I would look at before I decide it's a 22 gauge, 19 gauge length or the diameter of coil, I would see the diameter of the extramural part. And based on that, I would decide I need a 1 centimeter or smaller than that. And then here it looks like almost 1 centimeter. So 10 millimeter, that's the one I would use.
Yeah.
Do you guys
So we use
think that
that.
they look
Right.
so small is because we're, like, essentially
Decompressed.
decompressed, that it's
Yeah.
kind of a false reassurance?
It can be bigger, but right now, if we gotta put a coil, we gotta go with the diameter which has it right now. So based on that, we'll do, and it looks like a feeder is right there, and feeder usually is always in the right upper corner.
Always, yeah.
Yeah, always. And if you don't know where it is, it's in the right upper corner.
Right.
And so you pull the scope back and then try to go through the basically esophagus that you can
Yeah.
into intramural.
Awesome. Cool. So I'm going to continue showing the rest of this video. Oops, if it wants to play. Okay, so we start working distal, and we start deploying 14 centimeter length coils and pretty large diameter. And so we're deploying the second one now, and we're kind of marching our way all the way back. And now, if I can, okay, so we're stuck. We're landing the third coil, and we're stuck. And I've maneuvered, I've done everything, we've used a Kelly clamp, I've tried advancing the coil through, but half the coil has not deployed.
It's inside the.
It's inside.
Inside the needle and.
Inside the needle.
Inside the vent.
Yes.
Good plan.
This is the coil number 3?
This is coil number 3, but these are long coils, all 3 of them. Uh-oh.
Do tell, guys.
fortunately, I haven't had that, so that's a tough.
Yeah.
Dr. Tom, please. Somebody help
Yeah.
us here.
Somebody help.
Fortunately, I haven't had that situation, but the understanding is you can deploy the remaining coil into the GI lumen and then either leave it or come back later with scissors and cut it. So apparently, it's not a disaster to do that.
Yeah, I would leave it. Usually it's just that hole, you already have 2 coils in there. Just pull the needle and the scope back, and then after you remove it and to get it unhooked, then take another look with the endoscope, see how it looks like.
Okay.
Hopefully nothing exsanguinate.
Okay, cool. So we'll rock on. Let's move on. And then so obviously I'm trying to manipulate as much as possible to get that coil out. All my techs, every buff tech in the room is trying to advance this coil. It's not happening. Okay, so there you go. We deployed it in the lumen.
Not a huge deal.
No, it's happened. You can leave it. Coil, what what happens when it decompresses, sometimes the
always
coil
does,
comes
yeah.
up on its own.
Yeah, exactly. The body naturally rejects it.
Yeah, and also remember, before we actually use coil and glue, we used to directly inject into this thing aluminally. So
Yeah.
you actually even leave a hole in there by the time we're done. So that's where the glue comes in, is basically help to seal it as well. So that I don't think is going to be an issue, because eventually it's going to slough off and essentially, this,
I
you know.
still do that without needles. I'm like with the needle, inject it, mostly glue,
Yeah.
and that works really well.
Yeah.
Especially if you have a nice target.
Awesome.
This is no problem.
You guys all must have watched this video before.
No, but this is the reason why, I mean, in Orange County KP, we have 22 physicians, and to highlight the point that Dr. Sagayuki mentioned earlier, we only have 2 advanced endoscopists. We just don't want to be called at 3 o'clock in the morning for these cases.
Right.
I have no problem doing an elective case at 8 o'clock in the morning, but I do have problem 2 o'clock in the morning. So that's why I taught all my general GI physicians to come in. If they see a gastric like this and active bleeding, don't call me. Just inject it, because by the time I go to the hospital, the patient might not be there. So I still think, to highlight the point that direct injection still work and it works well.
Yeah, I love it. So obviously we want to do also Zeal therapy, reduce the risk of coil embolization. So, here you go. We looked at it for a long time, and then we decided to actually inject it also with glue. And as we were injecting, I don't know if you all can appreciate, this area started ballooning up a little bit. And so I'm going to pause here. Thoughts about that secondary ballooning of the varix adjacent to it as I'm injecting glue into the primary location where I place the coil. What do you all think? Should we touch it? Should we not? Should we leave it? What do we?
Just make sure there's a good flow in here, not just like not with the needle, but probing, and if it looks like it's still compressing, there's a good flow, then we just
Or, I mean, you could put Doppler on it again.
Exactly. Or put an EUS scope back down to confirm that you actually be able to, you know, to essentially thrombose that area
To see what's going on.
Exactly.
For sure, yeah. So we stopped, we didn't do that. But we decided to actually take the glue and we'll go right into it and inject it. And the patient, from this point on, actually didn't have any recurrent bleeding episodes. He's going through AA, so things are working well for him, hopefully. And I'll move on to the next case. Now, this is the last case. Yeah.
Why do you think it was difficult to push that last coil? Did you progressively go down in size, or be the same? Or?
So I went go big or go home, and I thought I was going to land at least 4 or 5 coils. And so I chose 3 long coils, the 14-centimeter ones, and that third one just didn't go. But then progressively, as the size was going to diminish, then I was going to use shorter coils. Yeah.
That's why what happens is like this is like if you use a bigger needle and shorter coil, that would give a problem. So you cannot be using like a smaller one which is for 22 for 19. That would give a problem.
I would have had a huge problem for sure. We use a 19-gauge needle, and so one consideration is probably being more aggressive about flushing the channel in between your coils. So because the blood can actually adhere to the coils, and we thought maybe that could have been a factor. All right, so this is a 73-year-old woman. She had a gastric sleeve 2 years ago. She originally presented to me with progressive oral intolerance and significant weight loss. Had a BMI of 16 when I first saw her. At the time, her imaging had revealed this sort of very severe gastric sleeve stenosis, tortuosity, no fissure or leak. I performed an EGD on her. At the time, her actual body of the sleeve was quite rotated, and we treated it both with pneumatic dilation and stenting for remodeling. She recovered quite well. She started eating solid foods. Her BMI went to 19. I performed an EGD 8 weeks after that, and I took out her stent. But then after, she comes back to me about a few weeks later and tells me that she's having regurgitation of solid foods, and I did an EGD on her at that time, and it revealed trapping of food in the proximal end of her sleeve. And so this is not the best image, but trust me on this, this is all food sitting in the proximal portion of the sleeve. What you see beyond that is the actual body of the sleeve. And so the lumen itself was patent, and the structural rotation had resolved by this point, but she just kept having all this food retained in her proximal sleeve. So this is without the food in place. So this is the proximal part of her sleeve. This is the lip that rises just after into the actual gastric sleeve, which is no longer narrow or rotated. And there's complete, patency of the lumen now. And so I'm going to pause here. Thoughts, considerations, questions. What would you do?
So just clarification, it's totally open.
It's totally
There's
open.
no blockage, there's no obstruction, just a little twisted, and that's it.
Exactly.
One option, this person went 2 years. We have a lot of these people who have gastroparesis, delayed emptying, problems with that. You can periodically, once a year, go in and just clean out any debris or residue, and stuff like that, or periodically. Did you do that and then see how she did, once you got rid of all the junk?
Yeah, she probably had 2 or 3 EGDs with me before we decided to move forward on potential additional therapy. But at that time, every single time, she had a large volume of food just sitting in this area, and it just wasn't moving.
Okay, so despite your going back and back, she keeps on getting symptoms.
Exactly. Yeah, she kept
And
regurgitating
sometimes
her food.
endoscopically, it doesn't quite correlate with functionally. So I think this, sometimes when you go into endoscopy, you pump a lot of air or CO2, you can extend the stomach, and you see anatomy that looks like it's pain. But I think this is where the GI studies would be helpful. A contrast study, or a contrast study, just to find out whether there's, in a normal physiologic state, whether there's a kink or angulation in such a way to preclude the food from passaging. Because I think that sometimes endoscopically we extend the stomach, we don't appreciate the difference in anatomy when it's actually a normal state.
Yeah.
I have a question. How long after you cleaned everything out would her symptoms recur?
Pretty much within a couple weeks. So she'd be eating solid food, and she loved chicken and pork, so it'd be sitting there in the proximal sleeve. We did an upper GI series, and it did show basically that there was complete patency of the lumen, of the contrast, but then there was still pooling of this liquid sitting in the proximal sleeve. So the issue we were all coming to was that this proximal sleeve was the issue, and the actual structure of it.
I would look at some sort of septotomy to take that down. And Mohammed, your group has been pioneering in terms of the double lumen, double axios kind of technique. But anyways, take down the septum.
That's one thing. The second is that's the problem that
Yeah, suturing.
why don't you reduce that?
Yeah.
Yeah, that's a good
That's what I was
question.
thinking, yeah.
Why don't
Yeah,
I?
Just like a pouch, suture it down.
I will, I want to say, as the surgeon on the panel, I absolutely agree with getting some kind of contrast study, which I'm sure that you got before, because looking at seeing how things are emptying. If this wasn't a 73-year-old woman, this was a younger person, the solution to this is a bypass. You convert them over, you can do short limbs if they don't need further weight loss. At a BMI of 16 and 73, we want to preserve nutritional status. But the hard thing is, she's done really well with the stent. You've, gotten things straightened out, but we don't know if at any other point she's going to have persistent kinking, angulation, and this dilated because of that outflow obstruction. So yeah, I think younger patient where you want more durability, we'd surgically switch them over. But for her, exactly looking at how do we kind of more normalize the pathway through this, we can. I have absolutely done, not so much just endoscopically, but opened people up when they have a stricture at like that incisura, because that's where these always happen in the sleeve, and done like a more formal stricturoplasty surgically. But in her, this big bubble is the problem.
Yeah, we spoke to her surgeon, and her surgeon was like, she's a really high risk of surgery, and converting her to bypass would have been really challenging. So this is our endoscopic option. I spoke to her about this potentially helping her. So we did do a septotomy, and we reshaped the sleeve.
You just heard from Dr. Missy D'Souza, our Hoag foregut and bariatric surgeon. We welcome her along with Dr. Katie Blevins.
Okay, so here we're doing a submucosal injection in preparation for the septotomy. So I almost treated this exactly like a septotomy for Zenker's. And we took a knife and we did a mucosotomy, and then we're getting down to the muscle. And what I chose here was actually the hook knife to actually start cutting through the muscle, and almost did almost a full thickness myotomy. So we're just cutting here, and cutting that muscle there. And then it wants to pause it. And so now this is post-septotomy. You could see sort of like the deflation of that lip a little bit. And so now we're thinking about closure. We chose endoscopic suturing to close here because it was almost a full thickness myotomy. We wanted to make sure the closure was quite adequate. And then subsequently after closure, which you see there on the right side, I'm reshaping the proximal stomach with suturing, with endoscopic suturing. And so you can see actually the sutures rotated. It's actually crossed on the bottom, so I rotate the scope all the way to the left, and that kind of relinquishes that twist. And then that's what the proximal sleeve looked like before. We decided to land a luminal stent to allow for remodeling. So this is our deployment of the luminal stent. And about 4 weeks later, we come back, I pull the stent out, and this is what it looks like. And that's the before and after. So her symptoms completely resolved after this. And we were able to save her from surgery. But this was, thank you.